Dear Chairman, thank you for the invitation to present an ABC 2020 meeting. The title of my presentation is Dumb and Dumber, Same Patient, Same Operator, Two Life-Threatening Complications and Many Wrong Decisions. My name is Đeiti Prvulović from Croatia, Clinical Hospital Center Rijeka. My first contact with the patient was in 2011 in the small general hospital in Croatia, cath lab with mobile C-arm and no cardiac surgery on site, of course. The patient at that time was 21-year-old male. He had myocardial infarction 8 years before that, with two bare metal stents deployed in a proximal LAD. He had preserved ejection fraction of 50 and completely asymptomatic till 1 hour before the admission. And now he has a typical angina with severe general weakness, dyspnea, diaphoretic, nausea, and he had a low blood pressure systolic of 80. On ACG there was a sustained VT, and after the cardioversion there was a QS in precordial leads with a ST elevation of almost 2 millimeters. And I am the operator. During the diagnostic angiography, I find diffuse, very significant in-stent restenosis in LAD, and there was a TIMI free flow, everything was okay. After changing and putting the guiding catheter, this is the image. There is TIMI one flow in LAD, and here you can see that there is excessive contrast staining in left main with TIMI one flow in LAD, and this is type D dissection with guiding catheter. I put the two guide wires and two wires in LAD and circ, and put the from ostium or of left main to proximal LAD this bare metal stent 4.0, 23 millimeters long, and after that there was a TIMI free flow in both LAD and circ, and I continued with two drug-eluting stents in place of restenosis in proximal LAD, and this is the final result. And you are probably asking yourself these questions: why bare metal stent in left main? Why no pot? And probably 80 or let's say 50% of you are asking yourself, why not final kissing deflation or pot, side pot in this provisional stenting of left main? But despite everything, the patient was very good and totally asymptomatic with a very active, physically active lifestyle, very satisfied with his life till 2018, when he came to the same hospital, still with no cardiac surgery, good X-ray equipment, but no IVUS or CT imaging, but no possibilities for imaging. Now he's 7 years older. He had pain for angina lasting for 3 hours, and with ST depression in lateral leads. And I am the same operator, 7 years older. This is the diagnostic angio. There is no restenosis in left main or proximal LAD, maybe some pinching of ostium of circ, and there are two de novo stenosis, subtotal stenosis in you can see it here, and in obtuse marginal. And this is the first step of my intervention, very stupid, trying to go through the struts of the stent. Predilatation of the side branch column is was easily and without resistance crossing the struts from left main to circ, and after the inflation back, really without the resistance, without previous pot side pot and pot kissing pot in left main. Stupid decision, but look at this. This is a drug-eluting stent, 2.5, 28 millimeters long, easily and without resistance going distally. Really couldn't cross the lesion in obtuse marginal. And Dunbar decision. I didn't deploy the stent. I tried to pull it out, and this is the second life-threatening complication for the same patient, done by the same operator. This is the total stent loss of the guide wire in situ. And I decided to put the balloon 2.020 in the stent. It couldn't cross the whole stent length. I inflated it I think three atmospheres and tried to cross the stent distally and deploy it in the circ, but it couldn't move. And I decided not to try any retrieval technique and to deploy the stent in situ, despite obvious mismatch between the stent and the vessel. It's the inflation of the balloon. And after that, I have a lot of difficulties with incremental balloon dilatation. I couldn't cross the stent with small balloons, ports of extra wire, body wire, Godzilla, and after that with non-compliant balloons and the final port in left main. This is the final result. Why final? Because I decided to stop the procedure here and to think what to do. My plan for tomorrow was femoral approach, final kissing of left main and ports, and to go distally with extra support wire if is it necessary, and to do the stenting of circ and obtuse marginal. But after thinking, I decided for the patient it's better to do it in another center with possibilities for forcity. It was done, everything was okay, but I think that time to take home message. We can discuss whether is it necessary to do a mandatory final kissing inflation of port side port in provisional stenting and left main. But after this case, we can have a take home message. Never attempt to deliver or extract a stent through another stent without removing the struts in front of the side branch. Thank you.